I'm going to allow our panel here our reaction panel, to provide some questions and feedback associated with the two positions. They've done a little research on that. They're both physicians, and they'll have some good comments to make regarding that. And then we'll open it up to the floor. So if I may. You guys will have to use a mic, it'll be easier.
I very much enjoyed both presentations. Just so I'm clear, I'm understanding things. Dr. Spetz, I think you, in your view of how single payer would work, essentially are using it as a way to eliminate the insurance companies and the cut they take out of the system, which I think many would agree seems to be a waste of funds. It's essentially the insurance companies are like the Enrons. They just take a cut as the money flows by without really adding anything to the system. But it seems to me that when you give the government this monopsony power, this solo buying power, there's a big risk of corruption and of wielding the big stick in order to have things done the way they want done. And I don't know what you would do to get the physicians to play along if you're in a position where you can, as Medicare does, dictate what fees are going to be, and where you've got the possibility, although patients would love it, of having fixed limited fees. If you can run a free country, the physicians would want to have the right to opt out or to have balanced billing or some system that would allow a privatized element of care as well.
Yeah, no, this is where my job of being the single payer straw man, putting up the single payer advocacy position kind of begins to clash with what I think would be more likely to work. In that the systems like Australia or even England now, where about 10% of people opt into a private healthcare insurance system, that a single payer system can provide an option, or perhaps the idea that single payer is for a basic health plan or a standard health plan that we all agree is necessary, but that there could be the option to buy above. But the fee thing is tricky in that Medicare now, I think, at least on the hospital side, which is where I'm more familiar with the data, is kind of an average payer. Hospitals don't make a lot of money on Medicare, but they're not losing money on it like they do with the uninsured and the Medicaid patients. And so to the extent that you could have Medicare administered by some organization that perhaps had a little bit of separation from Congress, that perhaps was operated by people who had some expertise, there were physician panels involved and so on, that's a trade-off that really becomes a social decision. Are people willing to make that trade-off? Physician salaries in Canada, when adjusted for cost of living, are not really lower than they are in the U.S. So, if you really want to go all the way to that, we're going to employ the doctors and totally socialize them. The closest example that we have on that doesn't have the doctors all getting completely crammed down.
Let me go on and ask a question of Professor Luft, if I may. As I understand your system, there are several major elements of change from the current system. One is you would eliminate or pass back to the patients expenses that they might reasonably cover out of pocket, non-hospitalized, not hospitalization, and non-chronic illnesses, which would certainly put a lot more discretionary power to the consumer, but it does open the door to the problem that there would be some people that wouldn't be able to afford that. The people at the lower end of the economic scale would still be struggling as they are now to find the funds to be able to take their kids to the doctor, themselves to the doctor. They delay care. People present with later stages of disease, and you haven't, I think, come up with a way to, other than maybe direct subsidies, to give people access to the system in that setting.
Okay, important question. I think most of us, even with a good credit card, line of credit, because we've been used to having an insurance company as an intermediary pay those bills, would choose to go to, in my example, Orange, and say, I'd like to buy a wraparound policy to cover all those minor things. Now, maybe I'll ask for a deductible and some co-insurance, et cetera, which would lower my monthly fee. And I'll then bear some risk, and those would be appropriately priced. The low-income people would find the premiums on that part of the policy as well subsidized. So low-income people can get subsidized there, because I think the vast majority of people will choose one of those, one of a number of different kinds of plans, just because we're used to carrying plastic rather than cash when we walk into the doctor's office. And so, and the nice part about what I'm trying to get at here is the physician doesn't know who's being subsidized or not. The fee is the same. So absolutely, I'm worried about that part. For low-income people, you subsidize it. You roll Medicaid dollars, safety net dollars into that. You still need a couple of small safety net programs for people who having a piece of plastic in their pocket doesn't work. There aren't many.
I shouldn't hog the mic, but I have to say, a second element of what you're saying, which I think is the most interesting thing, is really turning, as you say, data into information and empowering people to make better choices of medical care based on costs and outcome and quality data. And I think that's fascinating. My concern there is, though, you are, with your care delivery teams, correct me if I'm misinterpreting this, but I think this essentially amounts to a capitation payment for care, which certainly makes the knowledgeable people, the knowledgeable decision makers, the doctors in the hospitals, jockey among themselves for how this should best be allocated. But you didn't mention, maybe just because of time limitations, how you would deal with stratification based on severity, because if, depending on where one's hospital is or what a physician's practice pattern is, you're going to have sicker people than others, and some people may have mild patients, their diabetic patients are milder, they don't need as much time, maybe they're smarter, they don't need as much education, and they're going to require less time, less input.
Right. There are two aspects there. Let's deal with the patient severity aspect. And let's say we're going to pay for heart surgery. Very quickly, Stanford, UCSF will say, oh, no, we get the toughest cases. It can't just be open heart surgery. And the answer would be, okay, thoracic surgeons, what risk factors do you want to measure here? You don't need to go on a diagnosis and a procedure code. You actually have a whole set of risk factors that you've developed and you can collect and you can report, and we can do risk adjustment within that expanded DRG category. The part that I don't address is the physician who is working in, let's say, a low-income area with people whose lives are chaotic, who don't take their meds all the time, not because it's not paid for, but because they get ripped off in the street or things of that sort. I don't deal with that right now. But remember, all those Medicaid providers, the doctors who are willing to practice now can get paid at the same rates as everybody else. I think that I'm starting off with a couple of assumptions about most physicians, that they really like doing well and they're smart. That's actually one. So they'll learn how to work the system in ways that are appropriate. And two, most of them really care about taking care of patients. There are a lot who would be out there working in East Palo Alto, for example, if they could just make a bare living on it. So this will get them there. So it's not going to solve everything. And as I said, there will be some need for special grants, other kinds of outreach programs, et cetera. For, chaos is one thing. When you're dealing with people who don't speak the language and they need translators, you've got to provide subsidies for that as well.
I was going to just try and ask three questions to both of you, just give an overview of what I thought of each talk. Dr. Spetz's talk, I liked your talk very much, and I've long been an advocate of a single-party payer system in some form. We all like the idea of cutting out administrative costs and the overhead and things that are waste. Yeah, but starting off as Medicare as a model is a little problematic. Currently in Annapolis, Maryland, where I used to practice, there are no OBs taking Medicare because the cost of seeing patients was far above what Medicare was paying them. And in Massachusetts, where there is a state single-party payer system model of sorts, there's a vast shortage of primary care doctors there as well for the same reason. And of course, we have that same problem here in San Francisco and Marin, where there are town hall meetings with a dire shortage of primary care physicians because they can't afford to live here on the amount of money they're making. Dr. Luft, I like your talk as well. The managed competition model is an interesting one. It would take sort of large groups of physicians organized together to compete. It was based in managed care, and there's an apocryphal story about Dr. Eindhoven, who said that the primary care physician should manage everything. And then came to the emergency room at Stanford Medical Center with atrial fibrillation and said, "I want a cardiologist. I don't care how much it costs." And that will bring down to one of the three questions I wanted to ask. There's concern with managed competition about underutilization of healthcare resources with the capitation model. And I noticed when I came here from the East Coast that the hospital I'm at now has relative lack of information systems. And one of the reasons was that when managed care was big in the 80s, people didn't want to invest in healthcare information systems when they were capitated, and the goal was to get the patient away from the office as quick as possible. So the three things that I wanted to ask both of you are partly imputing on costs in either model and how they'd sort of be addressed. So the first is the patient who gets on internet and goes to Google, and whatever illness they have wants that expensive thing. They want that MRI for back pain, or they want the nth drug for a certain thing, or they want to be referred to a specialist. How do you, in each of the models, deal with that? The second thing is that I think a lot of the cost in healthcare is based on defensive medicine, so ordering tests to cover yourself. And neither one of you has really touched on an important issue in medicine, which is malpractice reform. And three is that a lot of the costs, if you're looking at the government taking over healthcare or managed competition, are based not necessarily on the physician outcomes or physician behavior, but on either a lifetime of patient behavior due to poor lifestyle, either by choice or by the upbringing of that they have. You know, in Marin County, the body mass index is among lowest in the nation, but it's not that way in downtown Oakland. And how do you solve those problems, which are going to be affecting the budget of whatever healthcare system you envision, when they're actually societal problems rather than medical problems?
Okay. Those are great questions. The patient who goes to Google and wants everything. I have a friend from MIT who, when she graduated from medical school, she was went from an inner city hospital where she did her residency to Alexandria, Virginia, and had a lot of patients from Mount Vernon, and that drove her nuts because she had everything from the vaccines are going to cause autism. Here's something I found on the internet about that. Through I want all these tests. You know, with single payer, the interesting thing with single payer is that you have an excuse to just say no. And I know that's very unpopular to say. Now I'm enrolled in Kaiser, so I'm kind of, and they don't actually say no that often, but they do. Okay, they haven't said it to me yet, but I think sometimes you have to say no. It's like you can't give everybody all the health care they could ever possibly want all the time without trading in something else. Look at our education system. Look at the state of our national state parks. Look at the state of our environment. These things all cost money. So by throwing money into health care for things that might be marginally beneficial, we are giving up other things. And so I don't have a problem with saying no. Now that puts a doctor in a bad place, and maybe that's what a single payer system does for them. Says, you can tell your patient no because I'm not going to pay you for it, but if your patient wants to pay you cash for it, they can go right ahead. If Dr. Eindhoven has the money, and he probably does, he can have the cardiologist. But, I don't have a problem with rationing. The problem with our current healthcare system is that rationing is occurring, but it's not explicit. It's all this, well, what insurance do you have, and which doctor did you manage to get into? Are you poor or are you rich? The rationing's all there, but it's not based on anything that I would view as medically sensible. It's based on poverty and social inequities and how much time you're willing to spend on the internet and then go find the doctor that you can stomp your feet and demand whatever, which is not a rational system. Now, maybe, we can have an argument about whether the government is rational. That's a whole different debate. But I'm an optimist. I think that Canada is much more rational about what they cover and what they provide than we are. And they cost a lot less, and their health outcomes are better. So even as much as we denigrate Canada's system in a lot of ways looks a lot better than ours. Defensive medicine and malpractice. Oh boy, that's not an area where I have a lot of expertise. I do know that California has a cap on the pain and suffering components of malpractice, and that's part of the reason we haven't had a flight of obstetricians in California as compared to other states. Again, I have a friend who graduated with me from MIT who doesn't practice OB anymore. Malpractice just got too expensive. And so there are malpractice reforms that could go into place, but I would hate to see that debate tied in too much with the health reform debate, and the reason for that is that any kind of health reform, you're going to have to fight against insurance companies, doctors, hospitals, etc. Add the lawyers to that, and you've pretty much guaranteed failure. You just can't fight that many battles at once politically. For costs, in terms of I think you answered your own question. You mentioned how do you solve what are basically social inequities, and I think you have to solve the social inequities. And that's another reason why I think you have to limit your healthcare expenditures at some point, because maybe some of that money that's going into extensive testing for things where you probably couldn't do a whole lot about it anyway, or the breast cancer treatments that are measured in tens of thousands of dollars per life day saved. Maybe some of those treatments could be used to actually provide education in poor neighborhoods and better food in the school so that the kids on school lunch are not getting the really scary stuff that I've seen my kids pass around the school. So there are other ways to handle those problems that would be a much better use of our resources than focusing all of that on healthcare.
Okay. I think Joanne's example or answer to the first question illustrates why I needed to come up with something different. But it's not really Joanne's answer, it's really Jim Kahn's answer. And the reason is physicians can't say no. When you've got a patient in front of you and it's ambiguous as to whether something's needed or not, it's awfully hard to say no. Now you can say, in this kind of situation, I just don't say yes. You can have the patient move in various directions. Patients won't stand still in America. In Canada, they will, because they moved north in 1776, the ones who like being told what to do. They were okay with King George. And the ones who didn't, the ones who don't want to be told what to do at all, are the ones who stayed south. So in essence, what I'm saying is you can choose whichever doctor you want. If you want to choose a doctor who, on primary care, will refer you to the specialist who does everything, you can. But what you'll find is that the amount coming in from that universal coverage pool, the difference is going to be higher for you because the net cost is going to be higher and you will pay more. But the data will still be there. We'll start being able to watch to see whether those patients who have those extra imaging tests done, those patients who have that new drug that may or may not be worthwhile, do they live longer? Do they have better outcomes? If so, it will start moving into general use. But in most cases, it won't. Honestly, I'd prefer experimenting on the rich than on the poor, especially with their own money. So I'm trying not to have the doctors be put in the situation of the rationing, of trying to ration, but have the patients choose what kind of practice they want to go to. And then let's see how that plays out. In terms of Canada does it well, but Canada doesn't have all the capital investment in hospitals and all the subspecialists who are used to running their own MRIs and their own lithotripsy units. And so the question is, it's not could we run like Canada, but how could we get to that situation? How would we choose which hospitals to shut down? That's where the lawyers get very exercised.
That's where the single delivery is not tenable.
That's right. It's how do you do that transition? Now, the defensive medicine piece, there's actually relatively little that's really done for defensive purposes. It's a really good answer when somebody has been trained to do that extra test or procedure and gets paid for interpreting it. To say, oh, I didn't really need to do this, I'm doing it because of the lawyers. I do actually have a solution. It's one piece of one chapter. In essence, saying, have very quick payoff to patients when something bad happened that might have been due to an error, a problem.
No fault?
It's essentially no fault, but I want to go beyond that, because right now, most cases are settled and sealed. After spending enormous amounts of money with lawyers on both sides, I hate saying this in a law office, but with lawyers on both sides, fighting about it until one of them blinks and they come up with a settlement. I'd say, make that settlement semi-confidential, so that any officer of the court, i.e. an attorney, can go in and look at that case and look for patterns of that problem in that care delivery team. If they've been screwing up multiple times and have paid off multiple times, they ought to know that there's a problem, and if they don't fix it, that's when you go after them with a corporate negligence suit worth a lot more money. Now, if they can be subject to that kind of suit, then they have a real incentive to figure out how to fix it. And they will go to the insurers, the malpractice insurers, and say, look at our data and everybody else's data and figure out who are the guys who are doing this procedure and not paying out lots. What are they doing right that I can learn from?